হ্যালো, আমার কথা শোনা যায়? কানেকশন না?
Yes, sir.
কেমন আছো তোমরা সবাই?
জি স্যার, ভালো
আলহামদুলিল্লাহ।
স্যার।
ঠিক আছে, ওকে। আজকে তোমরা তো ফোর্থ ইয়ার থেকে ফিফথ ইয়ারে, মানে নতুন ফিফথ ইয়ার আর কি, তো মেডিসিনের ক্লাস তো এর আগে হয় নাই, আজকে দিয়ে শুরু। কার্ডিওভাস্কুলার সিস্টেমের ক্লাস দিয়ে আমরা শুরু করতে যাচ্ছি। তো যে ক্লাসগুলি হবে তোমরা চেষ্টা করবা সেই ক্লাসগুলিতে অ্যাটেন্ড থাকতে। হ্যাঁ, so today I will discuss regarding some importance topic of cardiovascular system. So cardiovascular system, so clinical examination of cardiovascular system, you know, cardiovascular system is very important for medical examinations. It is important undergraduate as well as postgraduate students. So observation, when you will see the patient of cardiovascular system, observation, first of all you will what are the points to see? Patient is breathlessness or patient is distress, body habitus, patient is chaotic or patient is obesity or other features that consistent with uh, any specific disease such as smartphone syndrome. Tissue perfusion, when we will examine the patient, patient will see skin temperature, sweating, urine output. Hand, if you examine the hand in patient of cardiovascular system, some stigmata you will get. Clubbing, so clubbing is the most important clinical findings in medical examination. What are the cardiovascular cause of clubbing? Sometimes asked in bio examination. Cardiovascular cause of clubbing, usually complex congenital cyanotic heart disease, most commonly tetralogy of Fallot, and another is infective endocarditis. Another example is Eisenmenger syndrome. These three are the cardiovascular cause of clubbing. Another feature is splinter hemorrhage or other stigmata of infective endocarditis. Cyanosis, tendon junction. Pulse, usually radial pulse, rate and rhythm. Blood pressure, when you will examine the blood pressure. Carotid pulse and jugular venous pressure. Face, mouth, eye. When we examine the face patient is pallor or central cyanosis or dental caries or fundi. Any evidence of infective endocarditis, you will get infective endocarditis. You will get important stigma, maybe hemorrhage, maybe roth spot, or findings of hypertensive retinopathy in different stages. Or stigmata hyperlipidemia in the face, such as corneal ulcus or xanthelasma, and thyroid disease, maybe thyroid swelling in front of the neck, and precordium. In details, you will examine the precordium inspection, palpation, as well as auscultation. And back usually lung crepitation and sacral edema. You know, crepitation of the lung field. Bilateral crepitation is the important differential diagnosis of cardiogenic pulmonary edema. And sacral edema usually indicate the patient having heart failure when patient is bedridden. And examine the abdomen, you will get a hepatomegaly, ascites, aortic aneurysm, or hepatomegaly, usually tender hepatomegaly in case of congestive cardiac failure. But other cause of hepatomegaly, other cause of tender hepatomegaly, most important cause is liver abscess, viral hepatitis, hepatocellular carcinoma, maybe primary, maybe secondary, and congestive cardiac failure. So these are the important cause of tender hepatomegaly. Sometimes asked in bio examination. Ascites, ascites, cardiac cause of congestive cardiac failure is one of the important cause of ascites. Other than chronic congestive pericarditis, cardiac tamponade, these are the important cause of ascites. But other cause of ascites may be important in another system. Aortic aneurysm, bruit, any abdominal bruit, aortic bruit, or renal bruit, or hepatic bruit, So these are the related to cardiovascular system. Pulse, femoral pulse, radiofemoral delay and radiofemoral delay usually indicate coarctation of aorta. And legs, peripheral pulse edema vasculitis in patient with infective endocarditis. So in cardiovascular system, not only cardiovascular system, all of the system, when you will examine the patient, there are two components. One is general, other is specific. So every system you must examine in your clinical examination, because disease of one system, but this disease manifest in multiple systems. So you will get different findings from different systems. Investigations of cardiovascular system. These are the common investigation of cardiovascular system. Electrocardiogram, that means ECG. Cardiac biomarkers, cardiac biomarkers, troponin I, troponin G, creatine kinase MB, lactate dehydrogenase, AST, myoglobinuria. These are the important cardiac biomarkers. Chest X-ray, echocardiography, computed tomography, maybe CT scan of the heart, magnetic resonance imaging, MRI, cardiac catheterization. Usually, cardiac catheterization includes coronary angiogram or electrophysiological study and radionuclide imaging. So these are the important investigations for cardiovascular system. Presenting problems in cardiovascular system. Chest pain on exertion or severe prolonged chest pain. So chest pain is one of the important presentation of cardiovascular system. Another is breathlessness or shortness of breath. Number 3 is syncope. Syncope, sudden transient loss of consciousness with this continuous recovery. Palpitation or cardiac arrest. Patient is abnormal heart sound or heart failure. So these are the presentations. So cardiovascular patients of cardiovascular system present with different symptoms or different pattern. Maybe patient with abnormal heart sound, there is no other symptom, or cardiac arrest, or features of heart failure. Rhythm or cardiology. Another important term is cardiac arrhythmia and principal treatment of cardiac arrhythmia, maybe drugs, maybe non-pharmacological treatments. Coronary artery disease, there are three categories of coronary artery disease: angina pectoris, that is called chronic coronary syndrome or stable angina. Number 2, acute coronary syndrome. Sometimes asked acute coronary syndrome. What do you mean by acute coronary syndrome? Is a syndrome. It's a disease complex or syndrome. Includes unstable angina, elevated myocardial infarction, non-elevated myocardial infarction. And non-cardiac surgery patient with heart disease, some important role. Non-cardiac surgery patient with ischemic heart disease. When to ischemic heart disease, how to and why to, etc. Peripheral vascular disease, this is important. Peripheral arterial disease and disease of the aorta. Peripheral arterial disease may be artery of the lower limbs, artery of the neck or hands, and disease of the aorta. Aorta, maybe aortic aneurysm, aortic dissection, aortitis, Marfan syndrome, percussion of aorta, and hypertension. So these are the peripheral vascular diseases. Disease of the heart valves. Rheumatic heart disease, maybe acute rheumatic fever, chronic rheumatic heart disease. Number 2, mitral valve disease. In valve disease, maybe stenosis, maybe somehow maybe mitral stenosis, maybe mitral ligament deletion, aortic valve disease, tricuspid valve disease, pulmonary valve disease, and prosthetic valve disease, and infective endocarditis. So these are the diseases of the heart valves that may present with other disease of the heart. Congenital heart disease, commonly atrial septal defect, ventricular septal defect, patent ductus arteriosus, subtetralogy. This is the common congenital heart disease, but other congenital heart disease may be present, but that is not important for you. And these are the myocardium, these are the heart muscle, maybe myocarditis, maybe cardiomyopathy, maybe cardiac tumor. These are the pericardium, maybe pericarditis, acute inflammation, maybe acute, maybe subacute, chronic pericardial effusion, maybe tubercular, maybe not tubercular, chronic constitutive pericarditis, and cardiac tamponade. Problems in cardiovascular disease. Cardiovascular disease gives rise to a relatively limited range of symptoms. So cardiovascular is relatively limited range of small, almost symptom narrow, and a close relationship between symptoms and exercise is the hallmark of heart disease. So exertional chest pain, exertional dyspnea is very important for cardiovascular disease. That is why close relationship between symptoms and exercise is the hallmark of heart disease. And the Newark Heart Association functional classification is used to grade this ability. So Newark Heart Association class 1, low, no limitation during ordinary activity. Number 2, slight limitation during ordinary activity. Number 3, marked limitation of normal activities without symptoms or trait. Marked limitations. Class 2, slight limitation during ordinary activity. And class 3, marked limitation of normal activities without symptoms or trait. Class 4, unable to undertake physical activity without symptoms. Symptom may be present at rest. So, this classification denotes which pattern of disease may present. Differential diagnosis of chest pain. A patient present with central chest pain, there is different structure present in the central part of the chest, maybe heart, maybe aorta, maybe esophagus, maybe trachea, maybe mediastinum, maybe vertebral columns, etc. So, central chest pain, cause of central chest pain, important causes, cardiac cause, maybe myocardial ischemia, maybe stable, maybe unstable, myocardial infarction, maybe non-still-elevated, maybe still-elevated myocardial infarction, maybe myocarditis, maybe pericarditis, maybe mitral valve collapse. So these are the important cause of central cardiac cause of central chest pain. Number 2, aortic, maybe aortic dissection, maybe aortic aneurysm. Number 3, esophageal, maybe esophagitis, maybe esophageal spasm, maybe Mallory-Weiss syndrome, or maybe esophageal perforation. Another is pulmonary embolus, maybe massive pulmonary thromboembolism, maybe pulmonary infarction. Mediastinal, maybe malignancy, different type of malignancy. In mediastinal patient having mediastinal lymphadenopathy, maybe tuberculosis, maybe bronchial carcinoma, maybe lymphoma, maybe leukemia, etc. Anxiety, emotion. So these are the central cause of chest pain. Peripheral chest pain. Different organ are present, different structure, lungs or flora, or musculoskeletal or neurological. So, if patient is chest pain, maybe central chest pain, maybe peripheral chest pain. If patient present peripheral chest pain, you always try to think in three structures, maybe lung or flora, maybe pulmonary infarct, maybe pneumonia, maybe pneumothorax, maybe malignancy, maybe tuberculosis, maybe connective tissue disorder. So, these are the common important cause of lung or flora develop peripheral chest pain, or musculoskeletal, patient osteoarthritis, or patient rib fracture or injury, okay, or patient acute vertebral fracture, or patient osteochondritis, that means Tay syndrome, intercostal muscle injury, epidemic myalgia, that is called Bornholm disease, and neurological cause, prolapse intervertebral disc, thoracic outlet syndrome, herpes zoster. So these are the commonest cause of central as well as peripheral chest pain. Okay, so this is the central cause of chest pain: cardiac, aortic, esophageal, pulmonary, mediastinal, and this is the peripheral cause of chest pain. So this is important for your examination because in this year, this type of description have occurred. In OSPE examination, direct test of cardiac and non-cardiac chest pain, ischemic cardiac chest pain, describe ischemic cardiac chest pain, location, usually central or diffuse, the central chest pain, radiation, jaw, neck, shoulder, arm, occasionally back. So maybe jaw, maybe neck, maybe shoulder, maybe arm. Character is tight, squeezing, shocking. Precipitation, precipitated by exertion and or emotion. Relieving factors, rest, weak response to factors. Associated features, breathlessness, sweating, palpitation, dizziness, etc. So this is the characteristics of cardiac chest pain. Non-cardiac chest pain, location, usually peripheral, localized. Radiation, other, or no radiation, maybe radiate not. Character, sharp, stabbing and catching. Precipitation, spontaneous, not related to exertion, provoked by posture, respiration or palpitation. Relieving factors, not relieved by rest, slow or no response to nutrients. Associated features, other systems involved. So features depend on multi-system. So this is important for cardiac as well as non-cardiac. Chest pain. So you always try to remember. Chest pain on exertion. What are the important differential diagnosis of chest pain on exertion? Heartle buke bata hai. Heartle. Maybe coronary artery disease, maybe aortic valve disease, hypertension, cardiomyopathy, maybe pulmonary hypertension. So heartle buke bata hai. These are the usually cardiac cause, but sometimes not cardiac cause, the respiratory cause may present with chest pain on exertion. So these are the commonest causes. Clinical assessment, chest pain on effort is the hallmark of angina pectoris. Chest pain on effort, heartle buke bata hai, hallmark of angina pectoris. Maybe coronary artery, maybe non-coronary arteries. Okay. Physical examination is often normal but may reveal evidence of xanthoma xanthilation. Signs of anemia, signs of thyrotoxicosis, and cardiovascular system evidence of LV dysfunction or cardiac murmur, fluid or loss of peripheral pulse. So, chest pain or exertion, we will assess this patient. Maybe angina pectoris, maybe valvular heart disease, maybe cardiomyopathy, and examination. Not only cardiovascular system, but also we will search another system that precipitate or aggravate chest pain. Baseline investigation. Usually, first line investigation is complete blood count, fasting blood glucose, lipid profile, thyroid function test, and ECG. And second line echocardiogram, ETT, exercise tolerance test, coronary angiography, maybe CT, maybe PET. I will discuss some important talk regarding angina pectoris. Is a symptom complex caused by transient myocardial ischemia, which occurs whenever there is an imbalance between myocardial oxygen supply and demand. Factors influence myocardial oxygen supply and demand. Oxygen demand, usually cardiac work, heart rate, blood pressure, myocardial contractility, left ventricular hypertrophy and valve disease. And oxygen supply, coronary blood flow, usually depends on duration of diastole, coronary perfusion pressure, coronary vasometer tone, oxygenation, and oxygen saturation. Activities precipitating angina. What are the factors? Usually physical exertion, cold exposure, heavy meals, intense emotion, heavy dreams, or lying flat. These are the factors. Canadian Cardiovascular Society angina score. Class 1, angina only occur during strenuous or prolonged physical activity. Class 2, slight limitation with angina only during vigorous physical activity. Class 3, moderate limitation where symptoms occurs with everyday activities. Class 4, inability to perform any activity without angina or angina at rest, that is severe limitation. Management of stable angina. The principles of management involve usually careful assessment of the extent and severity of arterial disease. Number 2, identification and treatment of risk factors. Number 3, advice on smoking cessation. Number 4, introduction of drug treatment for symptoms control. Number 5, identification of high risk patients for treatment to improve life expectancy. So these are the management protocols, principal management. Careful assessment, extent and severity of arterial disease, maybe medical treatment, maybe intervention. Identify treatment risk factor, maybe hyperlipidemia, maybe diabetes mellitus, maybe hypertension, maybe alcohol. Advice is smoking cessation. Introduction, drug treatment for symptoms for maybe anti-anginal drug, and platelet, beta blocker, statin, etc. And identification high risk patient for treatment to improve quality of life. patient, high risk patient, diabetes patient, uncontrolled diabetes, severe hypertension, elderly patient, comorbid conditions. So these are the principal management of story, and this is the all about your